Okay, so here we are, chapter 5. This is in the next step, advanced coding. Again, in every video, I pretty much say how important it is to get through this book. Chances are, working through these cases are not necessarily going to teach you a whole lot of new things. What it's going to do is take the basic knowledge that you have and build on it. And you've got to have more than a basic knowledge in order to pass that board. So that's why this book, in my opinion, is a fairly significant book, because it just takes you to the next level of coding. Even if you don't get everything right, it's still just naturally, if you work your way through this book, will get you to that next level, and your chances of passing the board are just much, much greater. Okay, so here we are. We start with some debridement information. Good information, maybe will help you take some notes. This first case, remember you always read your italicized, and this is telling you that this patient's coming in during their 90-day postoperative global period. So that should flag your mind into knowing that you're going to have to use a modifier. Chances are it's going to be like an unplanned return to the operating room, something like that. So let's read the scenario and see. The patient has extensive fat necrosis, the lower abdominal wound following a paniculectomy. So she had a lot of extra skin that they went in and took out, and now she's developed some necrosis, some dead tissue. So they're probably going to go in and debride it, remove it and debride it. So here we go, it's a fat necrosis, lower abdominal wound. So all of that is a big flag that you're going to need this 78 modifier here. So a lot of your skin or integumentary codes are based on size. So it looks like a total of 60 square centimeters of sub-Q was debrided. So you need to go to your debridement section, and I don't even have my skin set up. So we need to go to debridement. And we know it's a sub-Q level. So you're under debridement here. Then you have to kind of find your depth. So we've got debridement sub-Q, first 20 centimeters, and then we're going to have an add-on for additional 20. So the code's going to need to be 11042-78 for that unplanned return. Nobody plans on having necrosis after a surgery. And then 11045-78 times 2 for that extra. So this is 20 square centimeters, and then this is another 40. Whoops, I'm trying to do something that isn't working. There we go. Your diagnosis is probably a lot of your skin diagnoses are going to be your L codes. Okay? So I don't think you'll have trouble getting those. It's going to, well, okay, one of them's, you're going to have to, this is a complication from a surgery, so you'll have to have a complication code. So probably an L7682. See if that works for you. And then the whole reason they had the surgery to begin with is all that redundant skin. And that's also, I'm not sure you can get there by redundant, but you can probably get there by a degenerative skin, extra skin. Okay, moving on. This is another debridement, fairly straightforward. This one has to do, I believe, with a complication of, patient was plated, so they have hardware in there, and now this is a complication of it. They've developed an ulcer. So the debridement code is not going to be too bad here. So they debrided 20 square centimeters of bone. That's going to give you your depth, so make sure you get as deep as that bone. And then your diagnosis is going to be, so we've got full, remember the post-op, we've got full thickness tissue loss over the left lower extremity medial aspect of the lower third of leg. So you're going to have an L code for that ulcer. Let's see if I can find. So procedures performed. They debrided the soft tissue, culture and sensitivity of the deep soft tissue, and then they ended up debriding out that 20 square centimeters of bone. So you're going to have that ulceration that they debrided out and took the culture and sensitivity on all the way to the bone. You're going to have a T code for the complication of an orthopedic implant, because this is infection. This would be an infection, complication of infection. They do let you know that that tissue loss is called an ulcer. I knew it was in there somewhere. And then there ends up being a fracture of the lower tibia shaft in here with everything going on. So just kind of follow that. This is a good discussion on it. Gives you a little bit, tells you why your 78 modifier is not needed on this one when we did use it on the other one. 2B, this is the same patient. Read this discussion, and I think you'll do okay with that. They're just, this ends up, they've got some pain. It's a radiology report. So they're going to do a duplex scan, and then they're going to, for the pain in the extremity. Okay, so moving on, your skin tags. You have a specific skin tag section for your skin tags, so you should not have any trouble with this. There is an added discussion. Your lesions, you have to remember that how you find the size of a lesion is you take the widest part, the greatest part of the lesion by the narrowest part of the margin, and then you times that margin times 2. So here, the lesion greatest is 1 centimeter. The margin is 0.5 centimeter. We double that. So your whole size of the lesion is going to be 2 centimeters. And we've gone over that. We did that several times in basic. So you should have that pretty good. This is an op report for removing lesions. Again, remember your diagnosis is going to come from your post-op diagnosis. If it is not definitive, then you're going to always default to your pre-op. Here's a pathology. So we just covered pathology the chapter before. So here you're going to get to determine your levels, and it's going to tell you that there was an intraoperative frozen section diagnosis by Dr. Lone Wolf. So make sure you have that intraoperative code represented. Here's a little bit of a discussion, might help answer a question. Again, here is an op report on lesions. Again, go with the post-op diagnosis. These are benign lesions. Okay. Lipomas, these are fat tumors, they're benign. Remember, when you're working with lesions, your simple closure is bundled in, intermediate or complex is not. So if they close in more than one layer, you're going to code that extra. So let's read here and see what it says, just to give you an idea of how to get this out. So the patient started lesion, removed this lesion, the first lesion, second lesion, it did the same. So you'll have to read this to know the size. It did the same with the smaller lesion, both appeared to be fat necrotic. Frozen sections were sent. We closed the skin. We obtained excellent hemostasis and brought a subcutaneous tissue together, so that's your first layer. Then we closed the skin, so that is a 2-layer closure. Okay, let's see here what this is. This is another lipoma. This is a lesion removal. So single layer, so skin layer is bundled in, but that's it. They made an incision, including margins. You'll have to know your size. They brought together the sub-Q, which is the fat level, and then the skin was closed. So again, this is a 2-layer, which makes it intermediate. Nevus. Patient's neck, excised the wound was closed. So all this is telling you the wound was closed and steri-strips were put on. So that's a single layer. They don't have any documentation of the sub-Q. They just say it was closed. So you have to make the assumption that it was just skin being closed. Epithelioma. Let's see, we made an incision. There's no context. We closed the wound with 2 sutures and a horizontal mattress. Here again, there's no indication that it's multiple kinds of stitches, but it's only 1 layer. Just kind of how you can read through these things. Make sure I got my. This is a keratosis excision. They're giving you the 1.5, so there's your, the lesion had been closed with interrupted, so they just closed it in a single layer on this one too. Don't get the subcuticular vicral, the types of sutures confused with subcutaneous layer of skin or fat. Here's a wide excision melanomas. Pretty much anytime you see a melanoma, it's going to be a wide excision because they really want to make sure that they don't leave a single cell of the melanoma. So this is melanoma of the left shoulder, 2 centimeters, wide excision. So this is going to be a pretty big. So the margin of about 3 centimeters laterally, medially around the incision, tapering to 4.5 proximally and distally. So bleeding was coagulated, incision was carried down. So it looks like the melanoma is 2 centimeters, and then the margins a margin of about 3 centimeters laterally and medially around the healed incision was taken, tapering to, so that looks like it's the smallest, so you times that, so that would be 6, 7, 8. So we need to be under excision of malignant, because melanoma is cancer. It is on the, what is it on? Shoulder, so we have to find our body part. Trunk of the body, so I'm under this 11600. Then I have to find the right size. So I'm at what, 8? So it's going to have to be 11606 over 4 centimeters. And that'll get you. And then let's see how they closed it. Bleeding was coagulated, the wound was closed in layers. So there's your intermediate closure. 11. Here's another melanoma. These are all very, very common. Then we get into this section of nails. Remember, they're reminding you here to use your hip picks. So here would be, this is from a podiatrist, 14-year-old with her mom, chronic ingrown lateral toenail. So this is for an ingrown toenail. Here's the assessment, chronic ingrown lateral border, right great toe. Repair and closures. You have simple, intermediate, and complex. So here is a laceration. The right and left ear lacerations. They cleaned and sutured them. 45-year-old was in a motor vehicle accident. Patient sustained ear lesion lacerations. So the patient is prepped and draped. The right ear is cleaned, and it's 5.2 centimeters. The left ear is cleaned, and it's 4.8 centimeters. The patient tolerated the procedure well. So it's just saying that they were sutured. So these would be simple sutures. You're going to combine them because you can combine like closures. And then for your diagnosis codes, you're going to have to, because they were lacerated, so you have a laceration of the right ear, laceration of the left ear. Then you're going to have to do some of that funny stuff with your ICD-10s. So it says here in your italicized, he slid into a ditch and struck a tree. Evidently, he fell asleep at the wheel. So you're going to have a Z code for lack of sleep, and then you're going to have a V code, V45475XXA, external cause code for a car accident, transport car accident by the driver that culminated in a collision. That will take you a little bit to find, but it's good practice for you. Modifier 59. These are also excellent modifiers to probably write down. These came about probably, 4, 5, 6 years ago. Good modifiers to have and to know about. Here's excision of another tumor. The 517, this is an umbilicoplasty. So they're coming in and they're doing, here, this is a complex repair. So they're kind of giving you a clue what to look for. And then you can just study how it's actually worded so that the next time you can pick it out yourself. But the surgeon's gonna repair an area of scarring. So if you look at the definition of your complex repairs, you will see that scar revision is part of a complex repair. So that's probably going to be, they're going to excise some granulation tissue or a fat necrosis, something like that. Then they're going to actually use a complex repair to revise the incision. And then I do believe they end up closing that. With an intermediate. So let's see here. Umbilicus is approached, attached to the stalk. Okay, so suturing back with a subdural, so that's under the skin, following by a closure of the donor area. So there's your 2 layers. It's kind of hard. You really have to read this stuff enough to be able to get rid of the fluff and the noise to get down to the actual parts that you need. 18, dermabrasion. There's a section on dermabrasion. This has a good discussion for that. Another dermabrasion, another scar revision here. So this is very good. You're going to get a little bit, at least get 2 looks at scar revision. So the first look was scar revision, and they used a complex repair to fix it. This one is removal of a foreign body. There's a scar that has a foreign body still in the muscle. So they're actually going to be removal of a foreign body from the muscle. Because it's the muscle and not skin, you're going to have to go to the musculoskeletal system to be able to get this. Because it's deeper than skin. Muscle is deeper than skin. Okay? So that'll be very, very good practice. And they tell you right here, the procedure performed excision of extensive 2.5, foreign body granuloma, and they talk about the nasalis muscles. So that's the muscles of the nose. So that gives you your depth. Here is a basal cell carcinoma wide excision. I think you'll probably do okay on those. Skin grafts. This brings into light again the percentages of your body. This is your split thickness autograft. Remember, you need to know auto, xeno, or allo. That helps steer you in the right direction. Always go with your post-op diagnosis. Muscle flap. This talks about the procedure performed, a split thickness graft on the thigh, and they're working on the soleus muscle. Here's a radiology ultrasound of that, probably checking for blood flow, making sure that, or there's an ulcer, maybe fracture, I don't know, they're probably still making sure that there's good blood flow. Full thickness skin graft. You need to know whether you're looking at the donor or the recipient on these. Your composite grafts. This is probably going to have an excision and then it's closed by way of a graft. You should have the answers in the back for this. Abdominoplasty. This is probably removing a lot of fat and then having to put the umbilical or the umbilicus or the belly button back in place. Probably for extra skin, so panniculus adiposus maybe. I don't know what it's going to say. So massive abdominal panniculus, so that's just extra skin. Your post-skin graft. A lot of these are fairly redundant. Again, just like we were kind of doing in the lab, this gets you back into the skin and kind of gets you good exposure. Looking at the codes again, having to read different codes, that kind of thing. Most of the scenarios are short enough that you don't get too frustrated. So just kind of keep that in mind. I think you'll be okay, especially with half of the answers being in the book. Here on this case 530, remember, always go with post-op. So left ischial pressure ulcer and osteomyelitis of the ischium. Those will play a huge part in your diagnosing. So looks like they're going to remove the pressure ulcer and then close it by way of a myocutaneous or a muscle to skin flap is what this looks like. So that'll kind of help you figure out how to code that. Pressure ulcer decubitus excision of the ischiums, probably like a 15941 maybe. And then that flap is going to be in the 157s somewhere. So that'll kind of help you get closer. Breast biopsy. So now we're in the very back of the skin section. Anytime all the breast stuff is back there. Pathology report, I'm sure, goes with this breast biopsy. You probably will have a breast biopsy or a breast question in your 10 questions of skin, I would almost swear. This one goes along with, so this is C to that. Here's a breast mass. Anytime you have your breast masses, you need to make sure you're looking at how much they took out. Was it just a lumpectomy? Was it an excision of a cyst? What did they actually do? So let's look here real fast. A standard breast line incision was made over the palpated mass, so they're still just gone to the mass. Sharp dissection carried down. Mass was grasped. The skin was closed. So all they did, so they excised the surrounding tissues. So they've done an excision And they're still calling it a mass. So what does it call it over here? So see, this B goes with A. So I would do whatever this diagnosis was. So it tells me it's a benign fibroadenoma. Okay? So that may, in your ICD-10 description, may come up as a cyst. I'm not exactly sure how that's going to come out. So the skin was closed in one layer, so there's no extra codes there. Remember to use a right or a left for your breast because we have mirror images. Your path report's going to have your leveling of that tissue. Remember, the tissue going in is a breast mass. 33, this is going to be another breast with needle localization. And then pathology of that. And 34, this is a segmental mastectomy with sentinel node injection. So that segmental is a partial, so this will be a partial mastectomy. I think they do go in and remove some lymph nodes. Then made an incision in the right axilla, so that's the armpit. We went down through the fascia, opened it up. It was a hot node that was blue. That's from the sentinel node. The counts were well documented. We sent another node, so that's lymph nodes. So that there's a lymph node excision, and then you have to code for that sentinel node injection because that's how those nodes turn to blue. And then I think it comes back that the patient has breast cancer. So that's a C50.9 something, C50.9 something. And pre-op consultation here. So it's a consultation. So this is going to be an E&M code. Here's a modified radical mastectomy. So now they're probably going to go in, and because it was positive, they're going to take it out. This is all the same patient, at least up to here. That's all the same patient. You have your answers in the back. I think you'll be okay. And then here's a mammoplasty. So they've probably had breast cancer and now are having it reconstructed. There's 2 mammoplasties here. Tissue expanders are very, very common with your mammoplasties to stretch the skin so that they can put the implants in. And that's it. I think you'll be okay. I think you'll be okay on this. So remember to, if you need the chapter 2 or the even answers, then to comment or send me an email and I can get them to you. Okay, I think I've guided you okay through that. So see you in the next video.